We routinely encounter individuals who exhibit relentless antagonism. They face severe physical consequences and social isolation, yet they show an absolute inability to alter their socially catastrophic behavior. Mainstream psychiatry's standard diagnostic approach assumes behavioral agency and structural neural integrity in these patients. When a patient demonstrates this profound lack of insight, diagnostics default to subjective labels like antisocial personality disorder or borderline personality disorder. Up to 40% of these high-conflict individuals possess an underlying structural or biological anomaly that remains undiagnosed during standard behavioral health evaluations. The medical model requires an immediate focus on diagnosing physiological hardware failures. Categorizing destructive behavior strictly within the confines of subjective surveys ignores physical brain architecture, resulting in the mismanagement of brain-damaged patients. The blood-brain barrier serves as the primary defense against circulating biological anomalies. Specific infectious diseases, including late-stage neurosyphilis and neurological Lyme disease, actively breach this defense. Once inside, these spirochaetal infections cause localized neuroinflammation that degrades the frontal and temporal lobes. Historical asylum data shows that prior to widespread spirochaetal screening, up to 30% of institutionalized psychiatric patients suffered from general paresis driven by these advanced infections. This frontal lobe degradation manifests behaviorally as sudden violence, extreme paranoia, and the complete erosion of social inhibitions. Viruses operate on a similar physiological override mechanism, specifically the acute encephalitis triggered by HSV-1. The viral infection induces a localized surge in cytokines, primarily TNF-alpha. This cytokine surge destroys brain tissue, leaving the patient with permanent necrosis in the frontal lobe post-recovery. In clinical settings, this localized structural damage mimics severe psychopathy. Neurologists identify this presentation as Kluver-Bucy syndrome, characterized by emotional blunting, hypermetamorphosis, and an inability to recognize social boundaries. Unchecked pathogenic neuroinflammation permanently rewires the host's capacity for empathy and threat assessment. Evolutionary biology requires parasites to actively manipulate host behavior to ensure their own survival and reproduction. The microparasite Toxoplasma gondii maintains a latent infection rate exceeding 30% globally. To rewire the brain's threat assessment centers, this pathogen encodes an enzyme called tyrosine hydroxylase. This equation models the resultant dopaminergic disruption, showing how dopamine synthesis increases alongside the pathogenic load. The baseline shift in neurotransmitter volume, represented by delta D, follows a linear regression. Dopamine levels rise as a direct function of the increasing pathogenic load, P sub T. This dopaminergic disruption is quantitatively linked to explosive aggression and a biological refusal of social preservation instincts. This neuromodulation extends into the gut-brain axis, where macroparasites execute a completely different hijacking strategy within the gastrointestinal tract. This tract serves as the production hub for approximately 90% of the body's serotonin and 50% of its dopamine. High loads of intestinal nematodes and cestodes severely disrupt the synthesis of these critical chemicals. These parasites also excrete neurotoxic waste into the host's bloodstream, triggering systemic chronic neuroinflammation. In advanced cases, this leads to the severe clinical outcome of neurocysticercosis. Tapeworm larvae travel through the bloodstream to encyst within the host's brain tissue. These brain cysts trigger extreme psychiatric breaks and erratic aggression, yet remain an underreported metric in diagnostic evaluations. Parasitic organisms hijack neurochemical supply lines and physically invade brain tissue to force host compliance. Heavy metals serve as a biological override vector due to their affinity for the brain's lipid-dense tissues. This data table maps specific toxins to their neurological targets and corresponding behavioral outputs. Historically, lead exposure was a highly pervasive environmental source for behavioral decay. Chronic lead exposure specifically targets the prefrontal cortex, destroying the brain's inhibitory networks. The toxicological threshold for this damage is remarkably low. Blood lead levels exceeding just 5 micrograms per deciliter initiate cognitive decline. As the blood level gauge shows, crossing this threshold correlates with significant visible reductions in gray matter volume. Without this structural architecture, the host becomes biologically incapable of mapping abusive actions to social consequences. Other metals, like mercury and arsenic, disrupt the endocrine system and alter neurotransmitter pathways. Mercury exposure induces erethism, characterized by explosive rage, paranoia, and an inability to accept criticism. Because mainstream medicine rarely mandates toxicological panels, severe metal poisonings are uniformly and incorrectly treated as toxic personality disorders. Persistent self-destructive behavior and antagonism are clinical symptoms of systemic biological compromise. The current medical establishment fails these patients by compartmentalizing physical health versus mental health. Talk therapy in staggered psychiatric management cannot cure bacterial infections, remove encysted parasites, or flush heavy metal toxicities. The data requires an immediate departure from diagnostics based on subjective behavioral surveys. Every behavioral evaluation must begin with a comprehensive quantitative diagnostic protocol, including heavy metal panels, infectious disease screening, and thorough parasitology tests. Diagnosing intractable behavioral disorders requires objective physiological proof before a psychological label is applied.